Good morning, everyone. Today I am going to present seminar on aminoglycosides, fluoroquinolones, and cephalosporin. Contents include introduction, fluoroquinolones, cephalosporin, and aminoglycosides, and these will be discussed under the heading of mechanism of action, classification, pharmacokinetics, important drugs, ocular uses, and adverse effects. So, quinolones, these are synthetic antimicrobials having a quinolone structure and are active primarily against gram-negative bacteria, though the newer fluorinated compounds also inhibit the gram-positive ones. The first member nalidixic acid introduced in the mid-1960s had limited usefulness and was earlier used for urinary and GI tract infection, and because of low potency, modest blood and tissue levels, restricted spectrum, and high frequency of bacterial resistance, it is not in use nowadays. So, a breakthrough was achieved in the early 1980s by fluorination of the quinolone structure at position 6 and introduction of a piperazine substitution at position 7, resulting in derivatives called fluoroquinolones with high potency, expanded spectrum, slow development of resistance, better tissue penetration, and good tolerability. So here we can see the nalidixic structure and the other fluoroquinolones which have a piperazine substitution at position 6 and at position 7 there is fluorinated compound which is added. So different positions of the carbon has different activity. So R1 control potency and influences pharmacokinetics. Same goes with R7. R2 is close to gyrase binding site and R5 enhances the gram-positive activity. The ketone bonds are crucial for enzyme binding, and the fluorinated compound enhances antibacterial activity and gyrase potency. So fluoroquinolones act by inhibiting bacterial DNA gyrase in gram-negative organism and topoisomerase 4 in gram-positive organism. So DNA gyrase is composed of 2A and 2B subunits, normally nicks double-stranded DNA and introduces negative supercoils and then reseals the strands to prevent excessive positive supercoiling during replication and transcription. Fluoroquinolones bind strongly to the A subunit, blocking its cutting and resealing function. In gram-positive bacteria, fluoroquinolones preferentially inhibit topoisomerase 4, which separates daughter DNA strands after replication. And higher affinity for this enzyme improves activity against gram-positive organisms. The resultant DNA damage triggers exonuclease-mediated digestion, leading to bacterial cell death and its bactericidal action. And the mammalian cells possess topoisomerase 2, which has very low affinity for fluoroquinolones, explaining their selective toxicity. Then the mechanism of resistance. So in fluoroquinolones, there are two mechanisms of resistance. One is chromosomal mutation and other is efflux pump. So mutations in the bacterial topoisomerase 4 and DNA gyrase prevent fluoroquinolone from binding, allowing replication of the bacterial genome to continue. Then bacterial modifications to an efflux pump can allow the bacteria to pump fluoroquinolones out of the cell. Then comes the classification. So the first generation fluoroquinolones introduced in 1980s have one fluoro substitution. In the 1990s, compounds with additional fluoro and other substitution have been developed, further extending antimicrobial activity to gram-positive bacteria and anaerobes and or conferring metabolic stability with longer T-half. These are referred to as second generation fluoroquinolones, and some of the newer ones have high activity against gram-positive cocci. So fluoroquinolones are divided in two generations. One is first generation and the second generation. First generation includes ofloxacin, pafloxacin, ciprofloxacin, and norfloxacin. And second generation include levofloxacin, lomifloxacin, sparfloxacin, moxi, gemi, and prulifloxacin. The first generation fluoroquinolones are active mainly against the gram-negative organism, and the second generation fluoroquinolones are active against gram-positive and anaerobes with gram-negative organism. It is The adverse effects include gastrointestinal adverse effects, which includes nausea, vomiting, anorexia, bad taste. Central nervous system adverse effect includes dizziness, headache, anxiety, insomnia, tremors, and seizures. Hypersensitivity, rash, pruritus, photosensitivity, urticaria. The serious cutaneous reactions are very rare. Tendinitis and tendon rupture. It has tendency of getting deposited in the cartilage of children. Hence, it is not advised that these fluoroquinolones should be administered in children. For topical medications, local burning, itching and discomfort, conjunctival hyperemia, white precipitates on corneal surface if used frequently in corneal ulcer treatment. Fluoroquinolones are contraindicated during pregnancy. Then comes interaction. So plasma concentration of theophylline and caffeine and warfarin is increased by ciprofloxacin due to inhibition of metabolism of the enzyme CYP-A12. So CNS toxicity can occur by concurrent use of theophylline and fluoroquinolones. NSAIDs may enhance CNS toxicity of fluoroquinolones and seizures are reported. Antacid sucralfate and iron salts given together reduces absorption of the fluoroquinolones. Ciprofloxacin is the most potent first generation fluoroquinolones and it is active against a broad range of bacteria and most susceptible ones are aerobic gram-negative bacteria. The minimum inhibiting concentration of ciprofloxacin against these bacteria is usually less than 0.1 microgram per ml, while gram-positive bacteria are inhibited at relatively higher concentration. And the highly susceptible bacteria are E. coli, Neisseria, Klebsiella, Enterobacter, H. influenzae, Shigella, Proteus, Campylobacter. And the resistant bacteria are Bacteroides, Clostridia, and anaerobic cocci. Ciprofloxacin is the most potent fluoroquinolone against Pseudomonas. Pharmacokinetics include oral bioavailability 60 to 80%, plasma protein binding capacity is 20 to 25%, elimination T half is 3 to 5 hours, route of administration is oral, topical, and intravenous. Doses include oral, which is 500 to 750 milligram BD. Intravenous is given in 200 to 400 milligram BD, and topical is 0.3% weight by volume for drops and ointment. Norfloxacin, it is least potent fluoroquinolone. The minimum inhibiting concentration of norfloxacin is 2 to 8 times higher than that of ciprofloxacin. It is primarily used for UTI and given for 8 to 12 weeks. The pharmacokinetics include oral bioavailability is 35 to 45%, plasma protein binding capacity is 15%, elimination T half is 4 to 6 hours. Moxifloxacin is a long-acting second-generation fluoroquinolones having high activity against Streptococcus and other gram-positive bacteria, and it is most potent against Mycobacterium tuberculosis, and it also retains its activity against Pseudomonas species. The bacterial topoisomerase 4 is its major target of action. It should not be given to patients predisposed to seizure and to those receiving antiarrhythmic drugs because it can prolong QT interval and combination may precipitate serious arrhythmia. The pharmacokinetics include oral bioavailability is 85%, plasma protein binding capacity is 40%, and elimination T half is 10 to 15 hours. Ofloxacin is less active than ciprofloxacin against gram-negative bacteria, but it is equally or more potent against Streptococcus pyogenes and other gram-positive cocci. The oral bioavailability is 85 to 95%, plasma protein binding capacity is 25%, and elimination T half is 5 to 8 hours. Ciprofloxacin and ofloxacin are the most widely used first generation quinolones because of their availability in oral, IV, and topical formulations. Levofloxacin is active isomer of ofloxacin, having improved activity against Streptococcus pneumoniae, Mycobacterium tuberculosis, and other gram-positive and gram-negative bacteria. The oral bioavailability of levofloxacin is nearly 100%, and elimination T half is 8 hours. The oral and IV doses of levofloxacin are similar. So, fluoroquinolones penetrate well into the aqueous humor after topical application. Moxifloxacin 0.5% has better corneal penetration and it achieves highest level in aqueous humor. Levofloxacin 0.5% also has good ocular penetration. Ocular infection suitable for treatment by fluoroquinolones includes acute bacterial conjunctivitis, blepharitis, keratitis, keratoconjunctivitis, dicryocystitis. And in systemic uses, it includes endophthalmitis, and fluoroquinolones are the drug of choice in the prophylaxis of post-op endophthalmitis. In gonococcal conjunctivitis and gonococcal corneal ulcer, first generation fluoroquinolone ciprofloxacin is used topically and parenterally in the treatment. The fluoroquinolones such as levofloxacin 0.5%, ofloxacin 0.3%, or ciprofloxacin 0.3% are commonly used first line agents to treat this condition as long as local prevalence of resistant organism is low. Treatment of bacterial keratitis. So fluoroquinolone is the usual choice for empirical monotherapy and it is as effective as duotherapy. Ciprofloxacin instillation may delay epithelial healing because of the precipitation of the drug on the cornea. Antibiotic duotherapy may be preferred as first-line empirical treatment in aggressive diseases. Empirical duotherapy usually involves a combination of two fortified antibiotics, typically a cephalosporin and an aminoglycosides, in order to cover gram-positive and gram-negative pathogens. So the degree of phototoxicity of potential fluoroquinolone is as follows. Most phototoxic is lomifloxacin, followed by SPAR, followed by Cipro, followed by norfloxacin. And the phototoxicity of norfloxacin, ofloxacin, levo, Getty, and moxie is similar. Then contraindication, previous allergic reaction to ciprofloxacin or other quinolones, certain disorder that predispose to arrhythmias. Fluoroquinolones are approved for use only in people older than 18 years of age. They are contraindicated in children and in pregnant women because they may cause cartilage lesion if growth plates are open. It is potential to cause teratogenic effects, also excreted in breast milk, and should be avoided during breastfeed. So this is the summary table of fluoroquinolones. Here we can see that ciprofloxacin, norfloxacin, ofloxacin, levofloxacin are available in topical and intravitreal preparation, whereas getifloxacin is only available in the topical preparations. Then comes cephalosporin. So antibiotics having beta-lactam rings are divided into major groups, which is penicillin, cephalosporin, monobactam, and carbapenem. So cephalosporin, they are a group of semi-synthetic antibiotic which is derived from cephalosporin C obtained from fungus Cephalosporium. It consists of beta-lactam ring fused to dihydrothiazine ring. So by addition of different side chains at position 7 of beta-lactam ring and at position 3 of dihydrothiazine ring, a large number of semi-synthetic compounds have been produced. Mechanism of action includes bacteria synthesizes UDP-NAM and UDP-NAG. These peptidoglycan residue link together and form long strands and split off UDP. So final step is cleavage of the terminal D-alanine of the peptide chain by transpeptidase and release of energy. Energy is used in cross-linking of neighboring strands, and cross-linking provides stability and rigidity to cell wall. So beta-lactam inhibit transpeptidases that cross-linking does not take place. So that cross-linking does not take place and cell-deficient forms are produced, and the interior of bacteria becomes hyperosmotic. So cell wall deficient forms swell and burst, leading to the bactericidal action. So this is the diagrammatic representation of the mechanism of action of the cephalosporin drug. Here we can see that cephalosporin basically binds to the binds to transpeptidase active site. Then comes the mechanism of resistance. So the acquired resistance to cephalosporin includes alteration in target protein, reducing the affinity of antibiotics, impermeability to antibiotics so that it does not reach its site of action, elaboration of beta-lactamases, which destroy specific cephalosporin, and upregulation of efflux pump. So here is the simple trick to remember the cephalosporin. So first generation cephalosporin includes fa in their pronunciation. The third generation cephalosporin ends with 1, 10, and I. The exceptions include that cephaclor, although fa comes in its pronunciation, it's a second generation cephalosporin, and cefuroxime, it ends with I, but it's a second generation cephalosporin. Fourth generation cephalosporin includes pi in their name, and fifth generation cephalosporin includes role in their name. Rest all other things comes under second generation cephalosporin. So first generation cephalosporin includes oral and parenteral drugs. So oral drugs include cefadroxil, cephalexin, and cephradine, and the parenteral ones are cefazolin and cefalothin. So spectrum of first generation cephalosporin, it is active against gram-positive cocci, moderately active against few gram-negative bacteria, and it shows no activity against enterococci, MRSA, Bacteroid fragilis. Second generation cephalosporin includes oral and parenteral preparation. It includes cefaclor, cefuroxime, and cefprozil, and parenteral ones include cefuroxime, cefoxitin, and cefoxitin is not available in India. The spectrum of second generation cephalosporin includes Streptococcus, Streptococcus pyogenes, Neisseria, E. coli, Klebsiella, H. influenzae, and Proteus. The third generation cephalosporin includes oral drugs which is cefixime, cefpodoxime, ceftibuten, and ceframide, and the parenteral ones include cefotaxime, ceftriaxone, ceftazidime, cefoperazone, and moxilectin. Third generation, the spectrum of third generation cephalosporin, it shows inferior activity towards gram-positive cocci and enhanced activity towards gram-negative organism. Pseudomonas aeruginosa is especially sensitive from ceftazidime and cefoperazone. The fourth generation cephalosporin are cefepime and cefpyrone. Fifth generation is ceftobiprole and ceftaroline. And sixth generation is cefidorocol. Fourth, fifth, sixth generation cephalosporin are given by parenteral route. The spectrum of fourth generation cephalosporin is active against Pseudomonas, active against methicillin sensitive Staph aureus and penicillin resistant streptococci, and it shows modest activity against anaerobes. Spectrum of fifth generation cephalosporin is active against few gram-positive cocci like Streptococcus, methicillin resistant Staph aureus, and penicillin resistant pneumococci. The spectrum of 6th generation cephalosporin, it is resistance cases of the Pseudomonas comes under are sensitive from the 6th generation cephalosporins. So, as we move from 1st generation cephalosporin towards 4th generation cephalosporin, the activity against gram-positive bacteria reduces, and as we move from 1st generation towards 4th generation, the activity against gram-negative bacteria increases. The pharmacokinetics includes that it is administered orally and parenterally, well distributed in body fluids, cross-placenta secreted in breast milk, 80 to 90% excreted unchanged in urine, and cefoperazone and ceftriaxone are excreted through bile, so can be given in renal insufficiency. Then this is the summary table of first generation cephalosporin. Here we can see that cefazolin is available in topical fortified, subconjunctival and intravitreal preparation, whereas cephalothin and cephalodrin are available in subconjunctival preparations only. Rest others are available in systemic doses. Second generation cephalosporin, it is available in the systemic doses. And the third generation cephalosporin, the cefotaxime, ceftriaxone are available in topical fortified preparation. Ceftazidime is available in topical fortified and intravitreal preparation. And ceftriaxone is available in subconjunctival preparations. Therapeutic uses. So acute conjunctivitis and blepharitis caused by gram-positive flora. The first generation cephalosporin, cefazolin, is effective. For gonococcal conjunctivitis and gonococcal corneal ulceration, third generation cephalosporin can be given in via IM and IV routes. And for bacterial corneal ulceration due to gram-positive flora, first generation cephalosporin, cefazolin by subconjunctival injections can be given. Then dacryocystitis and dacryoadenitis, second and third generation cephalosporin IV is given. Bacterial endophthalmitis combination therapy with ceftazidime and vancomycin is given. Pre or prophylaxis of post-op endophthalmitis include second generation cephalosporin, cefuroxime via intracameral injection. Pseudomonal keratitis and corneal ulceration, third and fourth generation cephalosporin with anti-pseudomonal activity and subconjunctival injection or systemic injection in case of corneal perforations can be given. Adverse effects include thrombophlebitis, hypersensitivity reaction, pseudomembranous enterocolitis, hypoprothrombinemia, prolonged bleeding time, disulfiram-like reaction, nephrotoxicity, neutropenia, thrombocytopenia, and cross-reactivity with other beta-lactam antibiotics. Fortified cephalosporin preparation. So cefazolin is prepared by reconstituting parenteral cefazolin 500 mg with 2 ml sterile water available with the injection and add to 8 ml of artificial teardrops. Ceftazidime is prepared by reconstituting 500 mg of ceftazidime powder for injection with 10 ml of sterile water or BSS. Ceftriaxone is prepared using similar method, and same goes with cefotaxime. Then intravitreal preparations of cefazolin, it is reconstitute parenteral cefazolin 500 mg with 2 ml of sterile water. We take 0.1 ml of this solution and make it 1 ml. Then comes the subconjunctival doses. So cefazolin is given 100 mg, cephalothin 50 to 100 mg, cephalodrin and ceftriaxone is given in 100 mg doses. This is the summary table of first and second generation cephalosporin. This is for third generation cephalosporin. Here we can see that ceftazidime is also available in the intravitreal preparation, and cefotaxime it is available in topical fortified drops preparations. Then comes aminoglycosides. So it has bactericidal action. First generation are effective against Mycobacterium tuberculosis. Second generation tobramycin is more active than gentamicin against Pseudomonas, whereas gentamicin it is more active against serratia. So pharmacokinetics, topically applied aminoglycosides are primarily absorbed through conjunctiva due to their hydrophilic nature. After parenteral administration, aminoglycosides are primarily distributed within the extracellular fluid. They do not penetrate well into the aqueous humor and vitreous fluid of the eye. Then aminoglycosides are a group of natural or semi-synthetic antibiotics having polybasic amino groups linked glycosidically to two or more amino sugars. These are highly water-soluble agents, not absorbed orally and do not penetrate the blood-brain barrier. Bactericidal agents are more active at alkaline pH and they primarily act against aerobic gram-negative bacilli and do not inhibit anaerobes. They have relatively narrow margin of safety. They are excreted unchanged in urine, and topically applied aminoglycosides are primarily absorbed through conjunctiva due to their hydrophilic nature. The classification includes topical aminoglycosides are neomycin and promycetin, and systemic are streptomycin, gentamicin, kanamycin, amikacin, tobramycin, sisomycin, netilmycin, and paromomycin. The ocular preparation of aminoglycosides are gentamicin, neomycin, netilmycin, tobramycin, and amikacin. The mechanism of action that they inhibit protein synthesis by binding to 30S bacterial ribosome if it is streptomycin and 50S subunit of ribosome if it is any other aminoglycoside, and cause inaccurate mRNA translation and so inhibit the synthesis of protein. This can be described in two steps. One is transport of the aminoglycoside through the bacterial cell wall and cell membrane via the porine channels, entry from the periplasmic space across the cytoplasmic membrane, and it is carrier mediated, which is linked to the electron transport chain. Thus, the penetration is dependent upon maintenance of a polarized membrane and on oxygen dependent active process. And the second is that binding to ribosome resulting in inhibition of protein synthesis. So here we can see when aminoglycosides bind to 50S subunit of ribosome, it results in inaccurate protein translation. So here we can see that gentamicin, the parenteral dose in adult is 3.5 to 4 milligram per kg per day given via IM or IV route and divided doses every 8 hourly. Pediatric dose includes 44 milligram per kg per day divided every 12 hours, and the adult dose of tobramycin is 3 to 5 milligram per kg per day, and the pediatric dose is 44 milligram per kg per day. Amikacin can be given up to 3 to 5 milligram per kg per day via IM or IV routes. Drops and ointment preparation are available for gentamicin and tobramycin, and only drop preparation is available for amikacin. For neomycin, for neomycin, sisomycin, and promycetin, drops and ointment preparations are available. For neomycin and sisomycin, it comes in 0.3%, and for promycetin, it comes in 0.5 to 1%. Then gentamicin is obtained from Micromonospora, higher potency and broad spectrum of activity. It is active mainly against aerobic gram-negative bacilli, including E. coli, Klebsiella pneumoniae, Enterobacter, H. influenzae, Serratia, and Pseudomonas. Some gram-positive bacteria are susceptible, especially the Staph aureus and Streptococcus faecalis, and it is insensitive against Streptococcus pyogenes and Streptococcus pneumoniae and MTB. Ocular uses topically it can be used in bacterial conjunctivitis, blepharitis, and dacryocystitis. Fortified eye drops are required to achieve a higher therapeutic level consistency in anterior chamber. These are used in combination with cephalosporin or vancomycin as initial empiric treatment of bacterial corneal ulcer. Subconjunctivally, it is used in the prophylaxis of endophthalmitis after cataract surgery. Systemically used in the treatment of ocular injuries, and intravitreally it can be used in cases of endophthalmitis. Amikacin is a semi-synthetic derivative of kanamycin. It is resistant to bacterial aminoglycoside modifying enzyme. Thus, it has the widest spectrum of activity. The relatively higher doses are needed for Pseudomonas, protease, and staph infection. Ocular use includes that it can be used the intravitreal injection of amikacin are used in combination with vancomycin or cephalosporin and is used in the treatment of bacterial endophthalmitis. Tobramycin, its antibacterial spectrum and pharmacokinetics are similar to gentamicin, but it is 2 to 4 times more active against Pseudomonas and protease. Cross-resistance with gentamicin is common. Ocular uses that tobramycin 1.4% topical is used in mycobacterial keratitis and infectious keratitis, bacterial conjunctivitis, blepharitis. Other uses is used in the treatment of respiratory infection due to Pseudomonas and cystic fibrosis patients. Neomycin, it has wide spectrum aminoglycoside, active against most gram-negative bacilli and some gram-positive cocci. However, Pseudomonas and Streptococcus pyogenes are not sensitive. Neomycin is highly ototoxic, nephrotoxic, therefore not used systemically. Then ocular use, it is used in the treatment of acanthamoeba keratitis in combination with other drugs. It is also used in stye and blepharitis. Topically for infected wound, ulcer, burn, external ear infection, and effects include topical application can lead to rashes. Oral neomycin has damaging effects on intestinal villi. Small amounts are absorbed from the gut or topical sites and are excreted unchanged by the kidney. So this may accumulate in patients with renal insufficiency and may cause nephrotoxicity. Streptomycin is too toxic for systemic administration and is used topically on skin, eye, and ear infection. So, the commercially available topical ocular aminoglycoside includes gentamicin, neomycin, trimycetin, and tobramycin. Gentamicin and tobramycin has been a go-to agent for the treatment of gram-negative ocular infection, especially Pseudomonas, and in conditions like conjunctivitis, blepharitis, blepharoconjunctivitis, bacterial keratitis, dicryocystitis, dicryoadenitis, and bacterial endophthalmitis. Nephrotoxicity is irreversible. Nephrotoxicity is reversible and ototoxicity is irreversible. It causes neuromuscular junction blockade by displacing calcium from neuromuscular junction, by displacing postsynaptic neuromuscular receptors and inhibiting acetylcholine release from motor nerve. Intravitreal injection may cause retinotoxicity. So this is the summary table of aminoglycosides. Here we can see that gentamicin, amikacin, and tobramycin are available in systemic, topical, and intravitreal preparation. Neomycin is available in systemic and topical preparation, and trimycetin is available only in topical preparation. So the summary of this presentation is that fluoroquinolones act by inhibiting DNA gyrase and topoisomerase 4, offering broad coverage with excellent ocular penetration, making them highly effective for conjunctivitis, keratitis, and prophylaxis of post-op endophthalmitis. Cephalosporin are derived from cephalosporin C and available in multiple generations. They act by inhibiting cell wall synthesis. They are valuable for treating gram-positive infection, gonococcal conjunctivitis, corneal ulcers, and form part of the standard intravitreal therapy for endophthalmitis. Aminoglycoside work by blocking protein synthesis at the 30S and 50S subunit, providing gram-negative and anti-pseudomonal activity. Drugs like gentamicin, tobramycin, amikacin are used topically as fortified preparation subconjunctivally, intravitreally in severe ocular infections. Overall, the objective of the presentation was to highlight the mechanism, spectrum, ocular applications, and major side effect of these drug groups, enabling rational and effective antibiotic selection in ophthalmic practices. Thank you.